Then it's a pleasure to invite Dr. Shreyas Ramamurthy, a dear friend, and like Dr. Rushad, he's one of the most, talented cataract, refractive, and cornea surgeons. So over to you, Shreyas.
Thank you so much, Shail, for your kindness, and thank you, Abhay sir, for having included me in your course. And I'm just going to present a couple of challenging cases, and I think that's what is wonderful about this session, and each of these are pearls which we'll all take home. So I'm presenting a couple of situations which almost all of us would encounter in our day-to-day practice, and what is it that we can do to make it better. So the first situation is the one with pseudoexfoliation. We all know that with pseudoexfoliation, while zonular weakness is commonly spoken about, the endothelial count being low is also a very common coexistent comorbidity. You can have pseudoexfoliative endotheliopathy and lower endothelial count as well. And I'm just showing an example of a case of an 80-year-old man with significant PXF, mild phacodonosis, and a grade 3 cataract with a poor endothelial count, as you can see on specular microscopy. So this is the surgical video, and always better to stain these eyes because you can run into challenges, complications later. You can see that the bag is quite mobile, and I'm having some difficulty in initiating the rhexis. So in these bags, as long as they are left as it is, there's not much which happens. It's only the trauma during the surgery that causes further weakening and complications. So initially what I do is I try to make a small rhexis, and you can see because the bag is moving, you don't have sufficient counter traction, becomes a little more difficult. So always use a micro scissor in these situations, and the micro scissor, even while using it, you can see that it is slightly deviating to the opposite side. So unlike in an intermittent cataract where you can just do it in one go, you may not be able to do so easily in a bag which is relatively weak. So you can even do it segmentally, as I've done in one side, make another nick along the opposite side, and then pull it. This way the amount of force that you're using to pull on the rhexis is minimized, and you're always constantly maintaining. You can switch between right and left eyes. Do a gentle hydrodissection, not too exuberant, but once you do the hydrodissection, in these cases where the bag is a little weak, I straight away go ahead and put capsule hooks. This greatly stabilizes the bag. You can have a nice 4-point fixation with the capsule hooks, because now it allows you to really rotate the lens with ease and then go about with your chopping maneuvers. And because the cataract is also reasonably dense, you will have to have a little bit of lateral separation. Not too much, but enough so that you can separate the posterior plate. And it's extremely important that the pieces are completely separated before you start emulsifying them, because any chance that the piece is not completely separated will pull the whole nucleus towards the center, which can increase the amount of zonular weakness. And it's important that you insert the CTR at an appropriate time. I can see that the posterior capsule has started billowing when I'm taking out that nuclear piece. Now, once I've removed a couple of pieces, I have sufficient space. I can push in this capsular ring without any stress on the bag, without moving the bag. When the entire bag is full with the nucleus, putting in the capsular ring can exert a little bit more pressure. So if you can chop and remove a couple of pieces safely and then put in the capsular tension ring, it becomes a lot less traumatic and without any stress on the zonules whatsoever. The capsule hooks also helps in this case, as it stabilizes the bag. You can use the capsular hook and the CTR in a complementary fashion. The CTR is going to stretch the bag and keep the PC stretched and down, whereas the overall bag is being stabilized with the capsule hooks. Subsequently, the rest of the phaco is fairly stable. You would prefer to use a 3-piece IOL in these situations. While this is a 85-year-old man, and I probably expect that this bag will last his lifetime, but patients, if they are a little younger, there is a small chance that some of these progressively over time may subluxate. In those cases, you can, it gives you two options. You can either refixate the bag itself, or you could convert it to a kind of like a glued IOL, SFIOL, using the same 3-piece lens inside the eye. So this is just the first case which I wanted to show, and I'll show one more situation and would like to have inputs from sir and the other panelists. This is another common situation which we would encounter. This is a patient with an intumescent cataract with a fairly dense nucleus. Now, again, in these cases, you would have two challenges. One, you need to have an intact rhexis to do your phacoemulsification technique, because there will be a significant amount of manipulation, lateral separation, and if you don't have an intact rhexis, it can become a challenge. So use a significant cohesive viscoelastic which pushes the capsule down, and this is, mind you, there are two types. One where as soon as you make a nick, you'll have fluid coming out. That is actually a good thing because that immediately decompresses. But whereas when you have this kind of fluffy cortex, it neither comes out and it continues to maintain the intralenticular pressure, and these are the cases where the runoff is much more likely. So ensure you use adequate tearing forces, make a small rhexis. After that, you can debulk the bag. And as I debulk, I remove some amount of the cortex. You can use IA or just a simple aspiration. And then you can make a nick and then enlarge the rhexis. In these cases, enlarging the rhexis is easier now that you have a dense nucleus underneath, you have sufficient support. Unlike in the previous case where I had to do it in a segmental fashion, here I can just go around and do it in one shot. It really doesn't make any difference. Then I rotate, ensure that I have good rotational, and then you can go ahead with the chopping. So in these cases, my preferred technique is to just make a slightly deep trench, which allows me to have a deep hold, and then go ahead with your chopping technique rather than with a direct chop, because with these dense nuclei, already where the fluffy cortex has been removed, the nucleus tends to be even more mobile than in a normal situation. So unless you get a really deep hold, when you're doing your chopping technique, the nucleus will tend to rotate and you lose the grip of the nucleus. So again, multi-level chopping, as you can see here, in each of the cases, the anterior part will splay open first, but you keep going deeper and deeper till it cracks all the way to the posterior and more towards the center as it separates right up to the central part. Once you have the central spine cracked, at least in one region, that is when you should start doing the phacoemulsification. Despite that, I'm just showing this particular piece, that you may have one heminucleus, despite whatever lateral separation forces you use, there'll be a small patch which is connected. And trying to push further more lateral force to separate that can be detrimental. So in that case, what you can do is just lift up the nucleus, like I'm saying here that there's with lateral separation, it's not separating. I'm lifting up the nucleus and then just slightly flipping it around, and then I crack the spine. So once that spine is cracked, then it becomes very easy to remove the leaflets which were attached to the central area. And even these dense grade 4, grade 5 nucleus can be aspirated quite easily. You can use viscoelastic in between, especially if you're in the last piece. Although with these newer machines, you really don't have much chamber fluctuation, but you can still go ahead and do it. And even in these grade 4, grade 5, you can get away with a decent CDE of around 24, 25, even in these very hard nuclei, if you've adequately chopped the cataract into multiple small pieces and makes the entire procedure easier. And with this repeatability, you can even implant premium IOLs in these patients. This is a trifocal toric going into this patient's eye. But one thing I wanted to highlight, because originally I'd done a double rhexis and extended, it was not a perfectly round or uniform rhexis. I wouldn't really mind if it was a monofocal. It's a sufficiently large rhexis. But in this trifocal, the rings are almost overlapping in this part. So it's important that if more phimosis happens, then more of the capsule is going to, over time, progress over the diffractive rings. So I just make a small nick and then extend the rhexis along that region so that I have a sufficient space between the diffractive rings, the starting of the diffractive rings and the capsular margin. And then you can have a well-centered IOL in the bag and can expect a good outcome in these cases. Thank you so much. Thank you, sir.
Excellent cases. Shreyas, would you, in cases of this kind of pseudo exfoliation, mature cataracts, do anything different pre-operatively in terms of your anesthesia, peribulbar versus topical, or injection mannitol pre-operatively, or anything different?
I mean, I would do under peribulbar block or subtenons. I mean, make sure that the patient is comfortable, because there is going to be some manipulation, likelihood that while you're stretching the retractors, there will be some contact with the iris at some point. So keep the patient comfortable. That's important. Apart from that, mannitol, I wouldn't say is an absolute necessity. If it's a short eye, maybe yes, but otherwise if it's a regular, because it's really the intralenticular pressure which is the problem here, and maybe reducing the vitreous pressure could help, but if you make a small nick and remove, like we've seen here, it immediately brings down the intralenticular pressure, and either mannitol or glycerol may not be absolutely necessary.
Yeah, Shreyas, very nice. I like that point. I do the similar thing where I create a deeper groove, probably sometimes even just make a crater in the center and then get a good hold for a brown cataract. That makes it easier. And of course, flipping the thing up for emulsifying that spine, that makes it a lot easier at the end of the day. Shell, just one comment on the Descemet's detachments. Very nicely managed. If we are putting gas, I would just like to reiterate that it's better to make a PI if we do that. Your cases had air, so perfectly fine without a PI, but if we are putting SF6 or C3F8, a PI is a good idea, otherwise we can sometimes end up in a pupillary
No, I think
block.
that's an excellent point, and all corneal surgeons, when they do their DSEC and DMEC, always advocate inferior peripheral iridectomy. I didn't do that in this case, and if you notice, the last case had an ovalization of pupil. She had an IOP spike the first day, which we managed, and because it was air, it came off very easily. But yes, that's also a very nice teaching pearl, that if you are injecting a full chamber with air, chances of IOP rise or pupil block, even with air, are also significantly high.
So I just like to, just apart from we've seen so many complications and so many managements and good managements. I think it's very important for us all as doctors and for junior doctors who are here and seniors, that we keep our instrumentation ready and up to date to handle crisis, because it is going to happen no matter what we do, no matter how good we are. So if we have ready instrumentation, good vitrectomies, triamcinolone in the place, iris hooks, CTRs, whatever is needed in place. So whatever we learn and whatever we discuss in conferences, we can implement when situation arises, rather than looking out for an instrumentation and not having. And the second more important thing is to also record all these videos, because the only way we can discuss and learn from each other is by having recording. So we record, like in our hospital, all the normal videos, so that whenever this thing does happen, we have something to discuss and show and learn from.
I think what I've learned over the years is that as a surgeon on the table, if you find that you're struggling and things are not going as you would like to, just go slow. The reflex would be to put the foot on the paddle more. Instead, lift your foot up, let sort of low flow rate, low bottle height, and so on. So just take a breather and go slower if you find any difficulty in your surgical path. So that's it.
So thank you, Shreyas. Thank you, Dr. Rushad, Dr. Samresh, for excellent teaching pearls throughout this course. And I thank the audience for attending and listening to this course. And we hope to see all of you next year as well. Thank you.